We're rolling.
Room 2.
I want to know what's going on. I just want him to get better.
He seems like a different guy.
As I said, I'm Thomas Sedlak, and Russell Margolis is my co-host here. And we have a number of disclosures for some of our research projects. And some of our learning objectives include the key positive and negative symptoms to make a diagnosis of schizophrenia, that there are new DSM V criteria for schizophrenia and how they differ from DSM IV, also understanding the roles of substance use and medication non-adherence in schizophrenia, and also the role of long-acting injectable medications, Clozapine, and some newer medication options. So now we'd like to introduce to you Scott.
My name is Scott. This is my bedroom. It's my parents' place. I went to community college for a semester, but it didn't work out.
Why didn't college work out?
I didn't understand. People hacked into my Facebook and posted lies about me. I could hear them talking about me.
Who was talking about you?
The other kids all avoided me. I could hear them talking.
What were they saying?
They were trying to make me fail. They talked trash about me. I stopped going to classes, but I could still hear them.
You left school because of these voices?
The teachers failed me. They didn't understand. They sent a social worker to check up on me, to get information. They don't know what I am capable of. They want to take my powers away.
Tell me about these powers.
I can fix things, heal things. I could heal you.
How do you feel being at home?
I tried to delete my Facebook account, but they keep it going no matter what. They want my information. I feel like they can hear what I'm thinking, too. She wanted me. That girl.
What girl?
What? At school. Here, my parents make me smoke outside. I still do it inside sometimes anyway. You smoke?
No.
A joint?
No thanks.
Do you have any unopened chips? I don't trust the leftover food in the refrigerator. They might be trying to drug me or poison me.
You say Scott has changed. Describe some of the ways he's different now.
Well, Scott's always been a challenge, but in the last year, he seems like a different person. He's suspicious and paranoid. He says things that don't make any sense.
It's a clear change. He had some issues in high school, but he's smart. He did okay.
He barely graduated.
Scott's school counselor thought he had a mild learning disability.
That's right. But I don't like what happened in that community college. He failed out after one semester. And there was some sort of incident. We were shocked. Now he acts angry.
Is he different with you?
He won't make eye contact. As Mom said, he's just a different guy.
Scott is a 20-year-old man who presents with a significant change in behavior over the last 12 months. His family reports that Scott exhibits altered sleep patterns, chronic marijuana use, agitation, irritability, suspiciousness, and auditory hallucinations. His parents note that Scott had some behavioral issues in high school, including poor attention and occasional disruptive behaviors in class. No formal psychiatric evaluation was performed at that time. At age 7, he was evaluated for ADHD, but no diagnosis was made. About 9 months ago, he was evaluated in the ER for a mild concussion he sustained playing soccer, with perhaps a few seconds loss of consciousness. He was discharged without treatment. His family history is significant for his paternal uncle, who was diagnosed with bipolar disorder in his 20s. Scott has no other significant medical, family, or social history.
You mentioned Scott seems suspicious or paranoid. Can you describe how he acts suspicious?
He stays in his room and smokes pot all the time. Doesn't matter what I say to him. He doesn't eat. Not what I make anyway.
He accused his mother of poisoning his food.
He accused me of the same thing, and we got into a big fight, but then he denied that it ever even happened. And he talks about voices that he hears and people reading his mind. It sounds crazy.
What about the incident you mentioned at the community college?
The school says he barricaded himself in his room and harassed some girl in the dorm.
He said the girl was totally in love with him, and he kept bothering her. From what I know, they barely even knew each other, but he kept saying that she was giving signals that they were going to get married.
I just want to know what's going on. I want him to get better. He's still my little boy.
And now we're going to segue into diagnosis and some comorbidities in a scenario such as this. So we got a lot of information there about Scott from both himself and his family members, and it's really important to get an additional history from an outside informant of some sort, because the patient can give you a lot about the mental status exam, what individuals who are somewhat disorganized or with cognitive difficulties may have some difficulty in relating the full story. But in this case, we heard about delusions, both paranoid and grandiose and erotomanic, auditory hallucinations, some mood fluctuations, sleep disturbance, decreasing academic and social roles, and then some confounding factors of marijuana. Perhaps there was some milder head injury going back. But in terms of criteria for schizophrenia, delusions and auditory hallucinations are most salient here, as well as the decreasing academic and social roles. Now, thinking about what might have happened that Scott is developing some of these symptoms, I'm going to take you just a quick tour of just some of the advances that have been happening. It wasn't all that long ago that this was one of the coolest slides in psychiatry, showing the genetic risk factors for schizophrenia. And down at the bottom, if you have monozygotic twins, you would have a 50% concordance rate. And then if you were first-degree relative, you have a comorbidity of about 10%. And with decreasing genetic relatedness, you reach about 1% prevalence of schizophrenia in the general population. But there's been a revolution of genetic understanding in the past several years, with a number of different schizophrenia susceptibility genes arising, some of these with point mutations in genes relevant to neurotransmitter transmission, especially in the glutamate pathway. And it's going to take some time to fully sort this out, but a few major points I think that can be made is that there's no single disorder here, but these are disease syndromes with a lot of different genetic contributions. There appears to be overlap with different syndromes, such as autistic spectrum disorder and intellectual disability, and that may explain why you have some of these features, even though the primary diagnosis may remain schizophrenia. And then also some caution that there, as of yet, isn't a major role for genetic testing in these populations, and the clinical approach is still the dominant one as of 2015. Now, how then do these genetic influences then impact the development of the disorder? It's been recognized for a long time that these are neurodevelopmental spectrum disorders in which adverse events with genetic contributions and during prenatal development may influence the susceptibility to the disorder. And it's increasingly recognized that there may be subtle signs that someone may be at risk of a disorder, at least retrospectively examining the history. Early on in childhood, there might be some evidence for cognitive, motor, or social impairments. They may be subtle. They may not be present or detectable at all. Then there might follow anxiety and depressive symptoms. Someone might initially suspect this is perhaps a mood disorder. Then there could be some social withdrawal, cognitive changes, and then maybe perhaps a little bit later, a more classic schizophrenia prodrome of social withdrawal, decreasing educational functioning, and then the full onset of positive symptoms, which would be required for a diagnosis of schizophrenia. The DSM-5 has gotten rid of the schizophrenia subtypes, such as hebephrenic and paranoid, and a more modern concept of schizophrenia would be that of symptom domains, in which there might be varying levels of severity of positive symptoms. I'm going to go back one. Positive symptoms, negative symptoms, and cognitive symptoms. There are wide varieties in cognitive domain deficits, including verbal learning, verbal fluency, attention, and psychomotor speed. Now, the DSM-5 diagnosis includes 5 criterion A symptoms, and you must have at least 2 of these. These include delusions, hallucinations, disorganized speech, disorganized behavior, and negative symptoms. So you have to have 2 of those, and then you must have at least 1 of the first 3, delusions, hallucinations, disorganized speech. And they must be present for a significant amount of time for at least a 1-month period. And then familiar from the DSM-4 and many other psychiatric diagnoses, social or occupational dysfunction. And then the disturbance must be at least 6 months, including 1 month of criterion A symptoms. You have to exclude schizoaffective disorder and mood disorders. And I note here that psychotic symptoms are not absolutely specific to schizophrenia, and also exclude the role of substance use, other medical disorders, and that a developmental disorder isn't the primary disorder. So when we speak of the syndrome duration being of 6 months, that includes the prodrome, at least 1 month of active phase symptoms, and then a residual phase in which the positive symptoms might have resolved, but the patient has not yet returned to their prior baseline. And a prodrome may or may not be present. So the total duration of at least 6 months, if not, then the diagnosis would be schizophreniform disorder, and the active phase of at least 1 month. So the DSM-5 has made a few changes to schizophrenia relative to DSM-4. Again, as I mentioned, they've removed the schizophrenia subtypes such as hebephrenic, disorganized, paranoid, because these do not appear to predict the course or treatment of the disorder. Catatonia is now a specifier for multiple diagnoses. Instead of just paranoid schizophrenia, you can have catatonia as a specifier for major depression, for instance, or bipolar disorder. And there are course specifiers: first episode, multiple episodes, full or partial remission, or currently an active episode. And criterion A is a little bit more straightforward, that there are no first-rank symptoms in the diagnostic criteria, such as voices arguing or giving a running commentary. For schizoaffective disorder, the changes have also occurred from DSM-4 to 5, and I think these are really going to change the frequency at which the diagnosis is given, and that was intentional on their part. Especially DSM-4 mood episodes had to be present for a substantial portion of the illness. They have now made this a little more explicit, saying that it should be present for the majority of the illness, more than 50%, so that recognizing that individuals with schizophrenia may have a major depressive episode or a manic episode, but if it's not 50% of the illness, then you would not give the schizoaffective diagnosis. And also, they've tightened up prominent mood symptoms and changed that to meeting the criteria of a major mood episode, fulfilling the full criteria of major depressive episode or manic episode. Now, in terms of comorbidities, Scott told us and his family affirmed ongoing marijuana use. And it's very clear from this and other lines of research that cannabis use and other substance use worsens the outcomes of the disorder. And shown here in the blue, individuals with ongoing substance use have a greater duration of hallucinations, delusions, and thought disorder over a year period. and even biomarkers such as gray matter volume. If you look at healthy comparison subjects, individuals with schizophrenia have a decrease in gray matter volume, and if they're using cannabis, then that volume is further exacerbated, the volume loss. So when we approach someone who may have a psychotic disorder and schizophrenia, again, there's a lot of exciting research developments, but we still have no fully objective tests, and you doing what you're doing in terms of the clinical diagnosis is still the gold standard criteria by the history and exam. But really, to get the best possible assessment, you need to have a full comprehensive interview and multiple informants if possible. These individuals may have limitations in providing full history, and you really need to talk to somebody to corroborate that and gain additional information. You also have to do some additional workup, evaluate for substance use, an MRI to evaluate for structural lesions that may be relevant, and blood work and electrolytes, thyroid function, syphilis, and HIV. And even still, early on, the diagnosis may not be fully clear, especially if you're within the 6-month window, or if symptoms might be somewhat ambiguous as to whether this is an affective disorder. But with a careful approach, a stable diagnosis can be reached, and over 80% might retain the original diagnosis in some centers. And now we're going to check in with Scott a few months later.
My parents made me speak to a doctor, a shrink. He gave me this medication.
Do you know what it is?
Risperidone. I'm supposed to take it at night. I think they're just trying to distract me from my work. My sister went with me.
What was the diagnosis?
It was nonsense. He said psychosis or schizophrenia, something like that.
But you take the medication?
Here it is. Take a look.
Do you notice any difference in how you feel or act?
I don't know. Act? I don't know what you're talking about. I feel more tired and my hand shakes sometimes. Look. It's them trying to keep me from my work. I eat on my own now, just to be sure.
Tell me how you take the medication.
I put it in my mouth, I swallow.
So you are taking it every day?
Some days, I think. I think it's nonsense. It's just another way for them to dull my abilities.
Scott's family brought him to meet with a psychiatrist 4 months ago. The workup included an MRI with contrast, complete blood count, metabolic panel, thyroid panel, syphilis and HIV tests, and urine drug screen. All findings were within normal limits, except for marijuana on drug testing. In the absence of other findings, Scott was diagnosed with schizophreniform disorder based on the presence of delusions, auditory hallucinations, disorganized speech, and negative symptoms, including reduced emotional expression, anhedonia, and asociality. He was initiated on oral risperidone 2 milligrams per day, which was increased to 6 milligrams a day over 6 months. He was also scheduled for weekly talk therapy with a therapist who works with his psychiatrist.
Tell us about Scott's visit with the psychiatrist.
It seemed like such a victory to get Scott to see the psychiatrist. You really help with that.
He seemed so bothered by the voices, and I told him a doctor might help and that I'd go with him if he wanted.
How has Scott's behavior changed since he saw the psychiatrist?
He put him on an antipsychotic. This is a few months ago. Honestly, I don't see much change. He sleeps more at night, so far as I can tell.
I would say he seems less agitated.
I think it makes him tired, and he also talks about that his hands shake, and I have noticed that his hands do shake sometimes. He also seems less expressive, like he has less facial expression.
How about his other behaviors, like the marijuana use?
I still smell marijuana all the time, so that hasn't stopped.
Actually, he ran out a few weeks ago, but he didn't want to leave the apartment to go get more. But that really didn't change his weirdness at all. I think he just slept less. Then that kid from high school came by and gave him more.
I never liked that boy.
Anyway, he says that it relaxes him, and eventually I got him to agree to leave the apartment by saying that we would go buy cigarettes. He told the clerk at the market that there were people watching him on the cameras and that he could tell if they were wired to another dimension with the others. And I don't know, I can't keep it straight between that and the government doing something. I think he was talking about the surveillance cameras at the store.
You all sound a little frustrated. What do you think is the issue?
We really wonder if the diagnosis is right. The doc said the medication should be doing something by now. Scott just doesn't seem much better.
Good. So we're going to talk about the insufficient response to treatment in this segment. So let's begin with the issues with Scott. He's clearly not doing well. He has side effects. Oops, let's go back. He has side effects such as sedation, tremor, less facial expression. His insight isn't very good. He's not taking his medicine on any regular basis. And if he said he's missing a few days, you know he's missing a lot more than that. And he's continuing to use marijuana, though even when he stopped using marijuana, he still had symptoms. So I want to talk about wrong diagnosis, substance abuse, and non-adherence, with particular emphasis on 1 and 3, since we've talked about substance abuse a bit already. First, wrong diagnosis. And I'm assuming detectable medical etiologies have already been excluded. So other disorders that can mimic schizophrenia, because remember, psychotic phenomena, thought disorder, hallucinations, and delusions are not specific for schizophrenia. Delirium, mood disorders. So individuals might have a mood disorder with psychotic phenomena. They may have autism with odd behavior that's mistaken as schizophrenia. Even more important, and I think more interesting for clinicians, is misinterpretation of phenomena in an anxious or distressed patient. Vivid thoughts that patients say are voices. So if you ask on a checklist without doing an in-depth interview, just say, do you hear voices? A patient is likely to may say yes, even though what they really mean is they're having vivid thoughts. Sometimes patients use voices as a general term for distress. This is becoming, I think, more common as the idea of schizophrenia is permeated into society. Societal fears now are becoming misinterpreted by clinicians as delusions. So, there's this talk. Patient says, I think the NSA might be listening into my cell phone. Well, the NSA listens into people's cell phones, and that causes us problems clinically, I have to tell you, in our unit, because I'm never quite sure what's going on. Particularly, we're about 20 miles from the NSA. And patients occasionally will malinger symptoms to get something that they want. What common diagnoses are found in these individuals? Often more than one. Some individuals have intellectual disabilities and they have difficulty expressing what they mean when they're describing their mental phenomena. It's easy to misinterpret them. A number of individuals have panic symptoms or depression with intense emotions that lead them to express themselves as though they were having hallucinations and sometimes delusions. Other individuals have a histrionic or have a related personality disorder, and some individuals are suffering from a collapse of their social network and under intense distress, regardless of what their baseline psychiatric or personality may be. Distinguishing among these things is difficult. Just as we don't have a schizophrenometer, we don't even really have an ability to define what schizophrenia is. It's a diagnosis of exclusion, after all. We don't have a hallucinometer, at least yet. Again, it's a close mental status examination, being wary of suggesting to patients that they have symptoms. And of course, the lifetime history from outside informants, just critical. I can think of all the mistakes I've made in the past when I haven't taken these things into account, and it's very embarrassing. Substance abuse for individuals who continue to have symptoms, as Dr. Sedlak mentioned, is a big issue, particularly marijuana. This particular study is a longitudinal study that shows that individuals who continue to use marijuana do much worse than individuals who stop using marijuana if you look overall over the course of several years. On this axis is kind of an index of general function, and these are the people who continue to use marijuana, these are the people who stop using marijuana, and they do better. Non-adherence, clearly Scott's issue. Big problem, frequent. No matter how you measure it, how you study it, it's frequent and it's going to be underreported. There's plenty of evidence that said if you ask a patient, you're going to get a wrong answer, a low answer, even so patients underestimate, clinicians underestimate it. Studies say anywhere from 1/3 to 2/3 of patients. I wouldn't be surprised if that's an underestimate as well. The problem with non-adherence is a direct correlation to relapse. This is one particular study of, I think, a couple hundred people over 5 years. Overall, 82% of this population who had a first episode of psychotic disorder relapsed in 5 years, but the predictive factors are really interesting. Premorbid function partially predicted relapse, about a 1.57 increased risk, but it's not taking their medicine that was the key predictor. This shows up over and over again in different ways in different studies. What's the best predictor of non-adherence? Well, it's non-adherence. It's what happened before. This is one particular study. Other studies will say the same thing. If you look at individuals and ask them prior to enrollment what kind of things were going on in their life, and if they weren't adhering to their medicines, their odds of adhering into the future are 4 times over the rest of the patient population. A few other factors contribute as well. But overall, prior adherence predicts with an 79%, nearly 80% level of accuracy, future adherence, and that's clinically valuable because that's the kind of thing that you will often have a good idea about when a patient comes in to a clinical setting. Conceptualization of non-adherence, I think, is useful in trying to frame a strategy for an individual patient. Their individuals' patient-centered factors include passive phenomena. The patient just forgets, or they're confused, or they're apathetic and they don't care. There can be other active measures, such as avoidance of side effects, belief that the medicine isn't helpful, and a general mistrust of treatment. And you can see many of these in our patient Scott. And then there are environmental factors that hopefully are being minimized, such as cost and access to care. In addition to some of the medical strategies I want to mention, there are psychotherapeutic strategies that are obviously important in minimizing poor adherence. Exploring patients' prior experiences. Do they have a particular prejudice against a particular kind of medicine, or do they have particular ideas that you might be able to persuade them are not accurate? Focusing on the patient's insight in their illness may not be necessary or useful. It may be that the patient can agree that the medicines make them feel better even if they don't think they have the illness. Improving the general attitude toward pharmacotherapy can be helpful, and establishing a long-term therapeutic relationship may be the most important thing of all, requiring a stable treatment team. There are specific adherence strategies. One, of course, is supervising a patient's receiving their medicine by caregivers, outreach teams, and the like. The second is the medicine delivery system itself. So they're beginning with rating scales where you're forced to ask a patient at each clinical visit, are you taking your medicine? And it gets a little more sophisticated than that. You can count their pills. There are electronic monitoring system where each time a patient unscrews the bottle of pills, it sends out a signal which can be picked up on a computer, and you know how often they're opening their pill bottle. Even that doesn't work so well, it turns out. There are automatic reminder systems where a patient gets a call on their phone. And just invented are pills that actually have a little chip in them that when they're swallowed, the chip is activated by stomach acid and sends out a ping that's picked up. It's actually been tried in a schizophrenia trial by John Kane, one of the pioneers of schizophrenia trials. And maybe there's something to it in the future, though one wonders about chips and pills and things. There are particular pharmacologic strategies. One is once-a-day dosing, which is possible for most antipsychotics, treatment of side effects, which we'll talk about later, The next set of pharmacologic strategy involves minimizing high doses of medicine. If you look at the dose of medicine most people need, you don't need more than 10 milligrams of Haldol in hardly anybody. Flufenazine, same kind of range. Olanzapine, maybe a bit more. The high end of this is not quite established, but most people need 10 milligrams. Risperidone, 2 to 4 milligrams. Aripiprazole, probably most people don't need more than 10 milligrams. So that helps because you can minimize side effects by keeping the doses as low as possible. And of course, we have long-acting injectable medicines, which I think are really important. We have 6 that are available, including the older ones, haloperidol and flufenazine, and oil suspension olanzapine, which is not used very often because occasional patients will receive a bolus injection by air and will become comatose. So very few clinics will use this. Risperidone microspheres, paliperidone, just released, is a 3-month-long injection, which might have some specific values in some cases, and aripiprazole suspension. Each of these has slight advantages and disadvantages in terms of convenience, but I think all are potentially great help. Look at this as an example. Here's long-acting injectable risperidone in a cohort of patients that were randomized. The rate of relapse is about 10% over a year. Oral risperidone, 50%. A really major difference in preventing relapse. Move on to Scott 6 months later. Scott showed poor response to a 6-month trial of oral risperidone of increasing dosages. On follow-up, several options were discussed with him and his family, including another drug test, adding a mood stabilizer, switching to an alternative second-generation antipsychotic, trying Clozapine, or switching to haloperidol. During the visit, Scott's sister mentioned that she had noticed some risperidone pills in the trash. This finding raised the possibility of poor adherence. However, Scott also described tremors in his hands, which could represent an extrapyramidal side effect. Although these effects are less common with the second-generation antipsychotics, they can occur.
Tell us what happened with Scott since we last spoke.
We got Scott to go back to the psychiatrist for another workup. This was maybe 6 months ago. The medication he was on was either not working or he wasn't taking it. The urine test was negative, so that was good.
It wasn't clear. He definitely wasn't taking all of them because I found some in the trash, but he must have been taking enough to get the tremor that the doctor was talking about.
Sounds like a mixed result. What did the doctor suggest?
The psychiatrist gave us a few options. Together, we decided to try a different antipsychotic. He proposed one that could be injected once every few weeks in case Scott wasn't taking the pills.
He did have to take the pill form of that for a few weeks before he could try the injectable.
Has the new medication helped?
Yes. He's been on the injection for a few months now. He seems so much better. He's more regular with the showering, if you remind him. He doesn't wear that awful shirt anymore.
He eats dinner with us too, and he talks to us a lot more without arguing about everything. If you ask him about the cameras, he still seems to believe it, but he doesn't just bring it up out of the blue or rant about it.
He still seems a bit laconic.
But he wouldn't say anything to me before. Yesterday, we talked about what he might want to do someday, what he might want to study.
And I think he stopped smoking pot. And when I asked him to quit cigarettes, he didn't run away from me. So that's progress.
Scott was switched from oral risperidone to oral aripiprazole for 1 month. At follow-up, Scott reported no side effects of treatment. He demonstrated slightly improved affect and ability to communicate. At that time, he was switched from oral to long-acting injectable aripiprazole.
I guess I'm not as worried about the other students and the cameras. I think that stuff is possible, but it doesn't seem to be bothering me. I suppose the medicine helps. I don't know if I have schizophrenia, but it helps calm my nerves. I still hear the voices. They whisper to me. It's better than shouting. I can ignore them now. The therapist has helped me ignore them. I used to think that was for other people, but therapy has made a big difference. The other day, I took the bus down to the library. Before, if I took the bus, everyone on the bus was talking about me and making fun of me. Now I'm not afraid to take the bus if I have to. My sister wants me to quit smoking. She says it's a filthy habit. I love smoking. She's alright, I guess.
Okay, so we're checking in on Scott again, and while he still is not symptom-free, overall it's clear he's doing better. His hygiene has improved, he's more engaged with his family. While he's still having some symptoms of delusions and hallucinations, they're less intrusive. He's able to ignore them more and get on with the functioning in his life. He has a little bit of insight. He still does not believe he has schizophrenia per se, but he feels the treatment is helpful in calming his nerves, as he says. He's getting out of the house more. You know, there's probably no one single thing that's responsible for this. The long-acting injectable medication has improved his adherence. He's also tolerating it better in terms of not having a side effect burden. He stopped the cannabis marijuana use. The family is engaged in his treatment. There's been studies showing that when the family is involved, the outcomes are better. And he is engaged in the treatment, and he likes the people he's working with. So all of these things are important in order to gain the best outcomes for our patients. But when we're going full speed with the treatment, you're going to be encountering side effects, and there are a great variety. One of the most difficult ones that I think we face is weight gain. And this has been a very difficult one. While the second generation antipsychotics have been an improvement in terms of extrapyramidal symptoms, they have added more in the way of weight gain. And shown here, if we use weight gain as a representative factor for metabolic syndrome, you can see that Clozapine and olanzapine induce the greatest amount of weight gain, whereas some of the less sedating second-generation agents, such as aripiprazole, are less, and ziprasidone, are less apt to induce weight gain. And some of the first-generation medications, such as fluphenazine and haloperidol, also on the left there, are less apt to promote weight gain. There are ways to address the weight gain. Shown here is a study using off-label use of metformin to promote weight loss. This is a randomized study of first episode psychosis patients who had add-on metformin or lifestyle intervention or both to their usual antipsychotic treatment. And you see on the far right, individuals treated with placebo and receiving their antipsychotic gained 3.1 kilograms, so that's close to 7 pounds. However, a lifestyle intervention resulted in 1.4 kilogram loss. Metformin, 750 milligrams a day, resulted in 3.2 kilogram weight loss. And then the combination use of metformin plus a lifestyle intervention was 4.7 kilogram weight loss. So what do you do when you're going forward with the best treatment interventions and the patient is still not recovering adequately? And not all antipsychotics have similar efficacy in terms of treatment improvement. Shown here is a meta-analysis of a number of first and second generation antipsychotics compared in terms of overall effect size. And you see first the treatment shift of the curve to the left is greater symptom improvement, and Clozaril has the greatest effect size. The question is raised, well, why are we not prescribing this to everybody? And currently, Clozaril is utile, especially in treatment-resistant cases. And a demonstration of this is an offshoot of the Katie trial, in which 244 individuals with a first episode psychosis, young individuals, average age of about 22, were treated with either increasing doses of olanzapine or risperidone, and you see about 75% had a response. However, 25% were non-responders. And you take those individuals and you treat them with another medication, such as going from olanzapine to Risperdal or vice versa. And in that case, only 17% respond from that initial non-responder pool. However, you take those non-responders and then treat them with clozapine, and then you get a 75% response. So again, this is demonstrating the utility of clozapine for treatment-resistant schizophrenia. And there still isn't a standardized definition of what we mean by treatment-resistant or treatment non-responsive schizophrenia, but generally it's either 2 or 3 trials of antipsychotic of adequate dose and duration with inadequate treatment response. And there's some debate as to whether or not one of those needs to be a first-generation antipsychotic. But again, if clozapine has the greatest effect size in terms of improvement, why aren't we giving it to everybody? Well, because as you see here, the side effects can be somewhat intimidating. I mean, there's a lot of sedation, hypersalivation, dry mouth, hypotension, lightheadedness, and very serious constipation that can be a medical emergency in some cases. Higher doses of the medication are associated with increased risk of seizures, especially if the blood level's above 1,000. Sometimes you need prophylaxis with an anticonvulsant agent such as valproic acid, but not carbamazepine, which can have an added effect with clozapine in generating a granulocytosis, which is the most infamous side effect of that, which tends to be early on in the course of treatment. And monitoring schedules have resulted in a decrease in fatalities. You have to be very conscious of myocarditis, so take chest pain seriously, order EKGs with cardiovascular symptoms, and follow creatine kinases and troponins as indicated, and show caution when combining clozapine use with benzodiazepines, which can result in sedation and respiratory suppression. However, despite these concerning side effects, why we wouldn't just give it clozaril to everybody? Most patients will tolerate these and will do well, and there are strategies to minimize each of these. Now, some of you may already be aware of the clozapine REMS program. This is a new registry that replaces the 6 previous clozapine registries. If you're going to be prescribing clozapine in the future, you're going to have to go to the website and sign up and take a knowledge assessment. If you're already prescribing clozaril, you probably have already done this. This program is notable for a few changes, especially that now only the ANC, the absolute neutrophil count, needs to be reported instead of that plus the white blood cell count. And there are now altered schedules for benign ethnic neutropenia, in which you can tolerate a lower ANC level and still have an individual treated as per clinician judgment, such as for general cases, the ANC has to be less than 1,000 now for treatment interruption and less than 500 if it's benign ethnic neutropenia. Overall, this new program gives the clinician greater flexibility to make individual treatment decisions if they feel the risks of treatment outweigh any potential side effects or risks. Now, in order to get the best results from our patients, medication alone is not enough, so we have to talk about non-medication interventions and also newer agents that are coming on the horizon to arm yourself in treatment choices.
Now let's look at some new agents that have recently come on the market that are of potential value to patients with schizophrenia. There's 2 new ones in particular that have been approved by the FDA. The first is cariprazine. This is an agent that is in the aripiprazole family. It is particularly notable in that it has high selectivity for the D3 receptor as a partial agonist, which may provide it with some unique cognitive benefits, though the extent of that remains to be determined. The most prominent side effects are akathisia, EPS, and the extent of metabolic effects remain unclear. Dose titration is quite easy over a couple days, up to approximately 6 milligrams. On the slide,
there is depicted one of the two phase 3 trials that were used in the FDA approval of this agent, showing that over weeks, as in most of antipsychotic trials, active agent separates out from placebo in a significant way, with the left axis being a standard rating system for symptoms. The second agent is brexpiprazole. This is already on the market. It's an agent also in the aripiprazole family. Unlike aripiprazole, it has high affinity for serotonergic and alpha-adrenergic receptors. Recently, the available evidence suggests there might be some mild weight gain, perhaps an increased incidence of akathisia, and a small increase in prolactin. Because of its alpha-adrenergic properties, the dose is titrated up over about a week. And again, as in the cariprazine study, if you look at the effect of the agent compared to very low dose or compared to placebo, doses of 2 to 4 milligrams, over a few weeks begin to separate out and have effect when measured by standard rating scales. What non-pharmacologic strategies are likely to be helpful in treating schizophrenia? This is essential because drugs alone clearly are not enough. From the standpoint of psychotherapy, there's clear evidence that group, individual, and family therapy is important, including support, cognitive behavioral therapy, and education for both individuals and for their families. Vocational and skill rehabilitation is absolutely essential, and ultimately leading to, hopefully, completing an individual's education and job training with on-the-job support so that individuals can enter the regular workforce. Case management and mobile treatment is often critical to make sure that individuals receive the necessary care and services. Cognition is another major issue in schizophrenia, as Dr. Sedlak mentioned earlier. Pharmacologic approaches so far have been of marginal effect, though there are major efforts underway to try and find agents which can improve cognition in schizophrenia. Non-pharmacologic programs, however, are actively being pursued and offer some intriguing possibilities. One of them is cognitive remediation treatment, which aims to improve cognitive function through cognitive exercises with the potential that it will generalize outside of the exercises themselves to all sorts of life activities. An additional method that has been developed is known as compensatory therapy. Essentially, individuals are taught how to work towards their strengths and to dodge around their weaknesses. And perhaps it may be integration of these two types of therapies together that might prove of the most benefit to individuals. This kind of intervention makes a big difference. Here's an older study, but I think it makes the point. If you look at on the left axis, it's the percentage of patients without a relapse in schizophrenia. For those individuals on medication alone, the relapse rate was something like 30-35%. Realize it's a log scale on the y-axis. By the time you add family treatment, social skills training to the medication, you end up with a relapse rate that's much, much lower. And this is really clear evidence that family treatment, social skills training makes a big difference for our patients. I want to give you a bit of evidence that this kind of intervention can make a big difference. This is an older study, but I think it points out how important interventions beyond medicine can be. If you look on the dotted black line, medication-only individuals have a very high rate of relapse. Notice it's a log scale on the y-axis. By the time you add family treatment and social skills training to the medicine, the relapse rate goes from something like 80%, 75% to down to 20%. Not that the exact figures are so important, but the fundamental idea is that medications alone are not the best approach. Individuals need a broad range of services, including interventions with their family and interventions to help them adapt to the environment. Finally, I want to end with a bit of optimism, that the long-term outcome for individuals with schizophrenia may not be so bleak. This is the famous study based on patients who originally ascertained in the Vermont State Hospital system in the 1950s. These were extremely ill patients. Retrospective reviews of their charts, even in contemporary times, have suggested that these individuals really did have schizophrenia, even by modern criteria. Followed up 30 years later, a large percentage of them are doing well. 85% or so not in the hospital the past year. Almost half of them employed. 80% able to meet basic needs, and 2/3 or 3/4 actually leading a moderate to very filling life. This is in part a reflection of the quality of care available in Vermont at the time. Medicines are newly available as these patients are emerging from the hospital, but it speaks to the fact that with time and with the correct type of services, individuals can actually do much better than what is typically appreciated.
We have a little time for question and answers, I guess.
Thank you very much. So we do have a few questions that are already written, so while I'm asking those, gentlemen, if you have questions from the floor, by all means, yell them out. Here's a question from a colleague. If marijuana makes outcomes worse, do we have an understanding in states where marijuana is legalized? How are those states doing?
That's an important question that we don't have an answer to. Certainly, epidemiologists are going to be taking a lot of interest in seeing in states where marijuana is more readily accessible, are the outcomes going to be different for these sort of disorders. So that's an important area that we should probably stay tuned.
Also, though, the rate in teenage use is really what's going to be critical, and that may or may not be affected by the laws.
Right. And as a follow-up question on marijuana, marijuana's got New Orleans all excited and worried. How bad is the risk, quantifiably, if a teenager is using marijuana, has the genes for schizophrenia? What is the propensity of marijuana to hasten the arrival of the illness or the severity of the illness?
There's some conflict out in the reports of that. Some of the larger studies will say a 3-fold increase in risk of diagnosing schizophrenia. There's some debate as to whether that's an earlier diagnosis versus total increased risk versus never having had the risk. A bigger study looking at 98% of the male population of Sweden over a 2-year period said smoking marijuana 50 times or more prior to age 18 led to a 6-fold increased risk 10 years later.
I think
others have replicated that to be about 3-fold increased risk.
Substantial.
Okay. Well, I guess the automatic question is then, what does one do about it? I mean, what's the scientific/practical approach you gentlemen take at Hopkins when you run into high-risk individuals or high-risk families regarding marijuana? Saying don't use it is obviously not always the only way to do it.
Of course, by the time we've seen patients, the cat is often out of the bag in terms of the onset. I don't think we have anything magic. I think this is a lot to do with family involvement, because one of the easiest ways, or most effective ways, to get rid of marijuana use by family intervention is cut the money supply. And sometimes it's tough love, though each case is different.
Understood. A colleague is acknowledging that genetics don't yet play an important role in the diagnosis of schizophrenia, but the question is, do you find genetic testing helpful when you're trying to select a medication, dose the medication, change medications, etc.?
There are 2 different types of genetic tests being proposed. Ones that might be deletions in spans of DNA that might be schizophrenia risk genes, and there's another set of tests that are more about metabolism of drugs, especially cytochrome P450 enzymes, drugs that making predictions as to whether a certain medication might be at higher levels or very low levels, depending on how strong someone's liver is. And it's something to consider, but oftentimes you're going to be going by the patient report as to whether or not they're having side effects. There's not really absolutely strong data that those sort of tests are exceeding your own clinical skill out there, recognizing whether somebody's taking the medication in the first place. whether they might be developing side effects that might be outliers in this response. But it's something to consider.
I would sharpen that in two ways. One is there's some reasonable evidence that 1% of individuals with schizophrenia have a deletion of the chromosome, which 22.
22.
And that because those individuals may have other related medical problems that could be detected, it may be worth paying attention to that, and I suspect that may become more standard. We do not routinely obtain the genetic testing for enzyme metabolism, except if there's something very funny happening. We might consider that.
Okay. Perhaps one last final question. Could you suggest some non-pharmacological means of modifying the weight gain seen with atypicals and schizophrenics?
That's hard. The problem is patients with schizophrenia it's hard for anybody to modify their lifestyle to change weight, and someone with schizophrenia on a medicine that's driving them to eat is hard. So I think it actually has to be a combination of pharmacologic and non-pharmacologic means, choosing the correct agent if weight gain's a problem. Family involvement is critical, and encouragement. I find it extremely difficult to do practically. The studies that have succeeded have been very, very structured exercise programs 3 or 4 times a week. And I think clinics who have tried that, if they really work hard and incentivize patients, I actually think in some way, shape, or form, paying patients to change their lifestyle is probably a cost-effective thing to do.
And there's some encouraging evidence. Again, part of our goal is to supplement medication interventions with non-medication interventions, get some structure in these individuals' lives, get them involved in a psychosocial rehabilitation program, and there have been some studies showing interventions with exercise in these sort of programs have led to some meaningful effects in terms of weight loss.
Yeah, one final question. This actually is from me because I'm often challenged by akathisia. So what are some of the Hopkins best practices when you not just encounter it, when you're trying to perhaps prevent it as well as to treat it and prevent adherence challenges?
Akathisia, minimizing dose, changing agent. Occasionally people will respond to things like beta blockers in the standard medicines, but akathisia is difficult. It's often difficult to detect and diagnose because patients are anxious and they're pacing around, and is it akathisia or is it part of their illness? So more medicine starts making things worse, then you really have to be on guard. So I'm afraid no magic, just the common sense, less medicine, switch agents, occasionally beta blockers, rarely anticholinergic agents can be helpful.
And part of your craft is, you'll get a question of, well, what's the best antipsychotic to start with, or what's the one we should start with? And there are a lot of individual patient factors that are relevant. Some patients are going to be more prone to akathisia, and medications like cyprazidone or lurasidone might be more prone to akathisia. Some of the medications more prone to weight gain have less akathisia. So those might be some factors. When you choose a beta blocker, things like propranolol have greater CNS penetration. Metoprolol is in the middle. Atenolol has almost no CNS penetration. So those are relevant factors if you're trying to get some CNS penetration to target akathisia.
Very useful. Gentlemen, thank you from me, and I'm assuming you too want to thank our colleagues. Wonderful. Thank you.